Good afternoon, everyone. All right, I think we can go ahead and get started. So I'll go ahead and introduce myself first. So good afternoon, everyone. My name is Maddie Haley, and I would like to welcome you all to the webinar series for the Autism Intervention Research Network on Physical Health, the AIRP. Thanks for joining us today. Because of the number of participants, your audio will be muted throughout the call, but you can submit questions at any point via the Q&A feature or in the chat box. If you would also prefer to raise your hand, that's fine too. This entire webinar is being recorded and will be available on the AIRP website, which I will put in the chat. If you also want to follow along with the slides, I will also put a link to do so as well. And then at the close of the webinar, there will be a short evaluation survey, which we would invite you to complete to provide feedback on this webinar and also to provide suggestions for future webinars. So in the interest of time, let's go ahead and get started. We first want to acknowledge the Health Resources and Services Administration as the funding source for the AIRP. And it is my honor to introduce our speaker for today, Dr. Rujuta Wilson. She is our neurology node leader and the assistant professor in pediatrics and psychiatry at the David School of Medicine at UCLA and also at the UCLA Center for Treatment for Autism Research and Treatment. So please go ahead and join me in welcoming Dr. Wilson.
Thank you so much, Maddie, and thank you for the welcome. Thank you everyone for joining today. I appreciate your time and I look forward to speaking to you on this topic. As you'll see, the title of my talk is A to Z's of Sleep and Autism. So I do hope to cover a broad range of items and we'll go through that outline as well. I do want to first say that throughout this talk, I do use both person first and identity first language. Partly this is due to some of the literature and resources that I'm citing. And I also use terminology to refer to things such as, excuse me, let me just move this. Apologies, my screen just froze for a minute. Things such as autism core characteristics or symptoms or traits, and this is really because some of the literature I discussed regarding treatment. But I do recognize that many individuals have different preferences, and my goal and aim is to be respectful to all. Maddie already noted that we are thankful for the support provided by the Health Resources and Services Administration, and the support of which supports also this talk too. And she also provided the introduction, so thank you. So here's an outline of the talk. We will be going over quickly sort of basics of sleep. Then we'll talk about sleep and autism. We'll talk about how we measure sleep, and then behavioral and pharmacologic interventions for sleep difficulties seen in autism. And then of course, we'll have questions and discussions. So what is the neurobiology of sleep? Sleep is a cycle that has signaling chemicals called neurotransmitters that control whether we're asleep or awake by acting on different groups of nerve cells or neurons in the brain. And these neurons in the brain, they connect the brain through the spinal cord. They produce these neurotransmitters such as serotonin and norepinephrine that keep some parts of the brain active while we are awake. And other parts or neurons of the brain begin signaling when we fall asleep. So these neurons sort of have a switch off signals that keep us both awake and keep us and then allow us to go to sleep. And here you can see in this diagram the different sleep cycles that we often move through: stage 1, 2, 3, 4, and 5, and the different things that are occurring during those sleep cycles. So what regulates the cycle of an awake and asleep? It's essentially this internal clock that we call the circadian rhythm. And we'll talk a little bit about, we have different hormones that and environmental cues that control the circadian rhythm. And it pretty much is this internal natural process that regulates the sleep-wake cycle and repeats sort of roughly every 24 hours. So why are we talking about sleep? Well, beyond the fact that many of us like sleep, I'm sure, it's very important for all aspects of health and well-being and has been studied quite a bit in terms of its importance with learning, cognitive development, memory consolidation, mood regulation, growth, and physical health. And we know this from studies beyond autism, what the benefits of sleep are and why certain sleep time and hours are encouraged. And we see through this infographic about sort of per age, how much sleep is required in general. And you can see in early infancy, these infants are actually spending the majority of the day sleeping. And over time, as your sleep cycle regulates, your circadian rhythm regulates, you develop more adult sort of sleep processes, one can see it moves from about that 17 hours out to about 7 to 9 hours of sleep. And particularly when we're looking at, across a lifespan, this is important, but we're talking about early childhood. Oftentimes we forget, even in that 3 to 5 years of age and 6 to 13 years of age, we're still talking anywhere from 10 to 13 hours of sleep, or more often 9 to 11 hours. So much more than what we commonly sometimes think about, which is that 7 to 8 hours of sleep. So now let's move on to the crux of what we're talking about. So what about sleep and autism? So we talked a little bit about basically what sleep is, some sort of basic ideas of the neurobiology. We'll talk a little bit more about some of the difficulties that we see in autism or issues in that area. We talked quickly about the importance of sleep, although we could give a whole talk on the importance of that. Now let's talk about some of the difficulties of sleep we see in autism and what that can lead to. So sleep disturbances occur in up to 50 to 80% of individuals with autism. And, that's a very high number when we think about all the individuals that we're taking care of and all the individuals that we're seeing in the clinic and the importance that we'll talk about later on in terms of screening. But when we talk about sleep disturbances in autism, we talk about across the board. We talk about difficulty falling asleep, or sometimes what we refer to in the clinical realm of prolonged sleep latency. We talk about frequent night awakenings, which we often call fragmented sleep. We talk about early morning awakenings, so that's shorter durations of sleep. And we often, because of these issues, we talk about daytime sleepiness and irritability. So let's talk a little bit about the etiology of sleep difficulties or impairments in autism. Behaviorally, some of the things that are thought are this sort of decreased awareness of environmental cues that can help habituate the sleep-wake cycle. This arousal dysregulation we call, so hyperarousal and increased cortisol at night, cortisol being a major hormone that can cause hyperarousal. Co-occurring diagnoses such as differences in intellectual ability or intellectual disability, sensory issues, ritualistic behaviors, and difficulty sometimes in communicating sleep difficulties are also thought to be underlie some of the behavioral implications of sleep difficulty in autism. Now let's talk now neurobiologically. We talked a little bit sort of briefly on normal function, or what at least we think, but some studies would have shown maybe alterations in this process. One of them has been dysregulated melatonin synthesis or altered melatonin secretion patterns. And we'll talk about a little bit more about this when we talk about treatment with use of melatonin. There's also been some studies looking at circadian clock gene anomalies. And so when we talk about that circadian clock earlier, that really regulates your sleep, if there's disruptions in that, how that can affect your sleep-wake cycle. And there's also been some studies that have shown normal melatonin secretion patterns. So the reason I highlight that, it's not that we know for sure this is the underlying etiology, but we've certainly seen some evidence that these could be altered. But there's still a lot to be done. There's also been some studies that have looked at what we call the hypothalamic pituitary adrenal axis. And they've showed that there's some dysregulation in this HPA axis, particularly underlying insomnia and autism, and also in association with some daytime stressors. And then another sort of viewpoint or insight that we've had on sleep difficulties is with the study of genetic syndromes associated with autism, and some of these genetic syndromes being associated with abnormal melatonin synthesis. So for an example of that being Smith-Magenis syndrome, where melatonin production is sometimes shifted to the daytime hours rather than what we expect to be occurring right before sleep. Well, what are some of the co-occurring issues that we see of poor sleep or the outcome of poor sleep? One of the other reasons why we're really looking to screen and treat for it. Well, poor sleep can really exacerbate maybe core or associated autism characteristics. It can have negative effects on mood and emotion regulation, on behavior and on cognitive function. And when we think about this, this is co-occurring difficulties in any of us, right? And any of us, when we have a poor night's sleep or multiple poor nights sleep, it affects the way we focus, right? It affects the way we're able to learn. We're grumpy, we're unhappy, understandably. So when we think about this being a persistent issue or a pervasive issue, you can really see it exacerbating a lot of other areas that an autistic individual or any individual are trying to undertake the next day. And oftentimes when we have a high focus on behavior or high focus on other areas such as attention, regulation, having poor sleep can really impact those areas. And so as I noted, this poor sleep can adversely affect your daily functioning and your physical and mental health. And I should really say not just for the child, or I should say individual, because we're also talking about adults, but also for the family who's trying to support this individual. It also causes risk for poor academic performance, increased risk for injuries the next day because of poor sleep and being drowsy. And, things like, and we'll talk about this a little bit more, coexisting conditions like reflux, epilepsy, which we commonly see in autism, anxiety, and ADHD can often further contribute to sleep difficulties. Another area is also restless leg syndrome, which I'm not going to get into depth here, but I'm happy to answer some questions. It's something that we may want to screen for as well. But that in general, that other diagnosis can also contribute to poor sleep. So how do we measure sleep? Well, the gold standard is an overnight sleep study, or what's called a polysomnogram. And this records EEG data, so electrical brainwave data, eye movements, heart rate, blood pressure, and blood oxygenation, as well as breathing patterns. It's generally combined oftentimes, or can be, with actigraphy, but not always. Actigraphy can also be a separate way that we measure sleep. And actigraphy, as you can see, this is a polysomnogram, this is actigraphy, monitors movements and can also monitor circadian rhythm, but more often is monitoring how many movements you're having overnight. And, I write here that this polysomnogram can be challenging to obtain in autistic children, but the reality is it can be challenging in any population to get this measure, let alone if you imagine having all of these on you. Any of us might have difficulty sleeping in the sleep lab to actually get some of this information. Now, it is important, but we also want to think about other ways in which we can measure sleep and other ways that can be easy screening tools for clinicians to use. Aside going over this, we do have other measures such as the Children's Sleep Habits Questionnaire. And I do like some of those questionnaires, but I like to refer to this slide and some of these basic questions because, again, it's fairly quick and easy to implement and often in the primary care setting. So in general, the recommended parameter or workup is all children with autism should be screened for insomnia or sleep difficulties. Screening should be done for potential contributing factors, including other medical problems. The need for therapeutic intervention should be determined, which we'll discuss. And then if there is a concern for obstructive sleep apnea or a central sort of process leading to sleep apnea, like a brain structural issue, or seizures, then there should be referral to a sleep specialist for this polysomnogram, the sleep study, or for an EEG. And here on the right, you'll see some of these basic screening questions, which is falls asleep within 20 minutes, falls asleep in the parent's bed, sleeps too little, awakens once during the night, and then screening for medical conditions such as snoring, apnea, weight, so obesity, which can lead to obstructive sleep apnea, asthma or difficulty breathing, seizures, anxiety or depression, like we talked about some of the behavioral factors that could lead to insomnia, or I should say mental health, constipation and pain. And then these ferritin levels really gets to the idea of restless leg syndrome, where in restless leg syndrome, we do evaluate ferritin levels because those have been associated to be low. And if that's the case, we would do some repletion with iron, which could treat that. Now, I'll touch on this a little bit, but I also want to note into the fact that many of these screening questions can often be present in many different children. And it's not that these immediately should say that we need to do a medical or behavioral intervention, but this is at least a cue into the clinician maybe asking or prodding more questions if a family is responding in a certain way to some of these questions. So here I highlight, and then I'm going to go in a little bit more detail because this came out a few years ago. It was and alludes for at least for clinicians to refer to this practice guideline put out by leading experts under the American Academy of Neurology for treatment for insomnia and disrupted sleep behavior in children and adolescents with autism spectrum disorder. And here what they really do is they lay out what data has actually been put out there and what data has been and the level of evidence associated with each of these areas. And what I'll tell you is there isn't much, there's some, and we're going to go through some of those treatments or through some of those medications. But this at least was an effort to bring that together and talk about what evidence is out there and perhaps what's needed. So what is first line treatment? Well, first line treatment is really behavioral. It really is addressing and thinking about what's going on in the home, what's going on at the bedtime routine, what are other associated factors or environmental factors, and how may we tailor this? And so, as I noted, what is the bedtime routine? What time does it start? Does it start really late? Does it start really early? And if we go back to that infographic that we saw of the different hours of sleep that's needed by different ages, if we're really thinking about 10 hours of sleep for in early childhood, and sleep time or bedtime routine is starting at 9, and the child isn't going to sleep until 9:30 or 10, but then needs to wake up the next morning at 6 or 7 in order to get ready for school or preschool or daycare, then we're really thinking about how we might want to shift that bedtime routine a little bit earlier. Because the reality being that oftentimes many of us maybe might be able to relate to this. You know, we're tired, we stay up late at night and try to push past that tiredness to get work done, to do something else. And suddenly you feel this whole wave of sort of, you know, I could stay up all night long because that arousal kicks back in and that hyperarousal kicks back in. So if we're really moving past what might be an ideal bedtime, that can affect your ability to fall asleep or sleep onset. Is there any screen time happening at night? And we'll talk a little bit more about this. Are they drinking a lot of liquids, which can lead to awakening overnight to go to the bathroom? Is there any caffeine prior to bed, or particularly in beverages that we may not know have caffeine in them, or teas or mixed drinks? Are there any other sleep aids that are being used? So the other example being oftentimes I hear about antihistamines, which can also sometimes lead to other sleep fragmentation. And are there any other medications? So SSRIs, selective serotonin reuptake inhibitors. These are things like Lexapro or Prozac, can sometimes cause you to stay awake. And stimulants are a very known medication used for ADHD, which can also affect sleep. So if an autistic individual also diagnosed with ADHD is being treated with stimulants for the first time, and they're coming into my clinic, or I'm treating that and we're seeing difficulties falling asleep at bedtime, we really want to think about at what time those medications are going to be used, whether we don't want to use an afternoon dose, whether we want to think about different extended release in the morning because it can affect sleep. And then also already what I alluded to, which is what time is actually the bedtime routine starting. In general, behavioral therapies for children under 5 usually include sort of graduated extinction, so sort of positive routines, bedtime fading. And older children and adolescents may respond to cognitive behavioral therapy. And there are a few pilot studies out there. There really aren't any major randomized clinical controlled trials, which I'll mention later. But there have shown some pilot studies that have shown some benefits of using CBT in older autistic individuals. These interventions are often short-term. They're multi-component. They're sort of goal-oriented therapeutic treatments aiming to modify thinking patterns and behaviors that might perpetuate insomnia. So these are things like the irregular sleep-wake cycles, poor sleep hygiene, and other maladaptive habits that can really affect your sleep, like I mentioned earlier. One tool that I often refer patients to or others to is something that's been put out by the Autism Treatment Network. And these are strategies to improve sleep in children with autism. And it's essentially a very nicely put together packet of behavioral strategies, first-line treatment and behavioral interventions and parent education to approach and utilize to start helping some of those bedtime routine and improve sleep hygiene. So here you can see a visual schedule also that is provided. And we'll kind of go through some of the other. So these are things, so you see the visual schedule, like putting on pajamas, using the toilet, washing hands, brushing teeth, drinking water, reading a story, going to bed and sleep. So these are sort of things that also a child or an individual can look at and be able to know, like check off even or mark the things that have been done. There are other things that they go through, like providing a comfortable sleep setting, establishing a regular bedtime routine, teaching a child to fall asleep alone, and promoting some daytime behaviors that can help sleep as well. This does extend to teens, so not just young children. And so sleep strategies for teens with autism. And some of these sections include things like evening routines, good food habits, a bedtime routine checklist, a comfortable sleep setting, and teen sleep practices. And I think the reality, and I'll mention this again later, is as you're getting into, adolescence, you are also thinking about the different patterns of sleep that are emerging. And so one thing that I'll say is sometimes what I find is as we're going into, that 12, 13, 14 years of age, maybe even younger, even 10 years of age, families are still understandably still trying to stick to that maybe 8:30 p.m. or 9 p.m. bedtime. And the reality is, even if that's ideal at 9 or 9:30 bedtime, there are some individuals who are going to start developing a slightly delayed sleep onset earlier, and maybe a later bedtime is more beneficial. And so the focus is going to be having really good behavioral techniques prior to that bedtime. So once that bedtime arrives, it's not then laying in bed for another hour and trying to fall asleep. So really, even though throughout this talk, as I give some of these studies or practice parameters or tools that we use, it's really modification to the individual and the family to make sure that overall we're promoting good sleep hygiene, but slight modifications that are going to be best for that individual are always encouraged. It should not be a strict, rigid routine. Some key tips that we take from this is really avoiding light exposure at night. So we want to avoid things like iPads and other screens. And oftentimes, what I say, and I don't go into depth in the literature here because I want to leave time for questions and other comments, is we understand that iPad, also very frequently used by children, can be a nice factor to maybe say, now we're going to calm down and wind down. But really that light exposure at nighttime is now well studied to show to disrupt sleep or to fragment sleep. So even if that's maybe something difficult to get away with close to bedtime, even though I like to say at least an hour before bedtime, if needed briefly to kind of wind down may be necessary, but within bed or within 30 minutes of bed or as falling asleep, we really advise against. Another area which we haven't touched on as much is exercise during the day. So in general, particularly in youth, it's recommended actually up to 60 minutes of sort of moderate to vigorous physical activity a day. And now many individuals may not be able to get that. Our hope is some of them are getting that in school. But even going for a walk after school, even including some other sort of movement of the body can really be helpful for winding down and leading to good sleep. Sticking to a good schedule and a routine is also beneficial, using that visual schedule in addition. Avoiding caffeine at least 5 hours before bedtime, and avoiding an eating or drinking right before bedtime, as I mentioned. So when we actually look at some of these studies, looking at screen time, and we see this study done here in pediatrics in 2013, what you see here in these two graphs are sort of average hours of time spent sleeping with no TV in the room and TV in the room. And then similarly here on the right with computer versus no computer in the room. And what we essentially saw was bedroom access, or what they saw, I should say, bedroom access to TV predicted less sleep in autistic individuals, and bedroom access to computer predicted less sleep in autistic individuals as well. So in general, when we're thinking about this, we really want to think about limit prior to bedtime, and generally in access if awakenings are happening, that we're not going back to the screen or looking or turning back on the TV. So now let's talk about treatments. And it's important to know that pharmacologic treatments, there's essentially no FDA-approved medications for autistic children for primary insomnia. And so when we're talking about pharmacologic treatments, we're really talking about off-label uses. And I think that's important to know, but I'm also providing here some of the studies that have been shown. But first, let's talk about melatonin, which we mentioned a little bit earlier on as well. And we talked a little bit about neurobiologically some abnormalities that we've seen in studies of autistic individuals. So endogenous melatonin is released from what we call the pineal gland, which we saw much earlier in that pictograph of their circadian rhythm when it gets dark. And this release of melatonin promotes sleep. It works both as a hypnotic and promotes sleep, and it stabilizes circadian rhythm. So it works on two particular receptors, M1 and M2, and as a hypnotic to promote sleep and also stabilizing the circadian rhythm. It also acts as sort of an anxiolytic to mitigate hyperarousal. So essentially it helps shut the brain down and keep the brain calm prior to bedtime. So again, kind of going back when I talked earlier about how this can be maybe dysregulated in autistic individuals, we think about this potentially being an etiology of not allowing you to promote sleep, stabilize your circadian rhythm, and perhaps leading to more hyperarousal. So let's talk about the use of melatonin. Again, noting that there's no FDA-approved meds for primary insomnia in autistic children. And so some of the things that I'm going to highlight in terms of treatment are very much what's in the literature. I'm going to add in comments about what I do clinically, because these are individuals across a lifespan that I see in my clinic, often coming for sleep difficulties. And some of this is also used by what we see as beneficial anecdotally, but also supported, of course, use of meds by some of the literature that's out there too. So one of the first medications I'll talk about is melatonin immediate release. And these are all over the counter. It's important to know also that they come in gummies, in liquid and tablets. So for that reason, it can also often be friendly for individuals across a lifespan to take or to use, or those who aren't using tablets. And it's beneficial for sleep onset, right? Not sleep maintenance. So really sleep onset. We usually are starting with a dose, or what's been shown, about 2 to 6 milligrams. So I'd say in a younger individual, or in general first starting, I usually start around the 2 to 3 milligrams. And it's important that it's given 30 to 60 minutes prior to bedtime. So I mentioned earlier, or I should just say in the slide before, but even when we looked at that circadian rhythm, that melatonin is produced when it starts getting dark, right? And so to really augment that endogenous melatonin, we want to use this exogenous melatonin around that same time. And sometimes what I often run into are individuals who are using it, or families maybe right before bedtime. So plan is to get into bed at 8:30, they're giving it right at 8:30, or trying to give it overnight when somebody wakes up. And that's not really going to augment the melatonin that we're naturally producing. That's why for it to be most beneficial, we want it to give it prior to bedtime. What's also really important is this consistent use of melatonin, and what I also say is a sleep log. So we don't try to use it one day and then off one day and then a few days and not again. And I'll allude to this a little bit later in terms when I summarize, but we want to use it nightly when initially. And it's really helpful, although I know an additional thing to do, to keep a sleep log to understand how well it might be working and how long it is taking to fall asleep, and whether or not we truly are shortening the duration of that and improving what we're trying to address. And we may, of course, increase the dose if it's not working. So in sort of several, as we move along, if initial 2 milligrams, I'll go up to 4, maybe 6, perhaps up to 10. But at that point, you really want to be thinking about whether or not melatonin is useful. There's also melatonin extended release, one of the names being Rameltion, for example. These also can come as over-the-counter tablets. And there have been studies that have shown effectiveness in improving nighttime awakenings, and then helping not just sleep onset, but sleep maintenance or duration of sleep overnight. And some studies also showing improving some daytime difficult behaviors and quality of life in caregivers as well. So I alluded earlier also to that the sleep guide put out, and there also is a melatonin, a sleep guide for those using melatonin as a guide for parents. And some of these sections include what is melatonin, why might supplemental melatonin help children with autism, what are the risks, whether I know it's working, and if melatonin doesn't improve sleep, then what are maybe some options or next things to go to. So another toolkit to maybe refer to if you've already used melatonin or you're treating somebody in which melatonin is being put on. I'm going to pause just for a second to take a look at the chat just to see if there is. So I see a few different, what I'm going to do is I'm going to go ahead and finish up because I don't see a hand raised, but then I will address those questions at the end as time permits. And I do believe we should have time for that. So let's talk a little bit quickly about safety of melatonin. And so there have been a lot of concerns for melatonin, its safety, and its concern for side effects of melatonin, particularly on puberty. So one of the thoughts is that melatonin drops at puberty. So there are some worries that if you give this, then it can cause early puberty. And one study that I want to highlight is, this was led by Dr. Beth Mallow. She is a leading expert in autism and sleep, and I would recommend looking up her name, many of the studies that she's written, majority of those that I cite here today, and other work that she's doing as well to really address this. And so this study essentially was a 3-month double-blind placebo-controlled trial studying the efficacy and safety of pediatric prolonged release melatonin. And it was dosed at a nightly dose of 2 milligrams with an optional dose elevation up to 5 to 10 milligrams for a long duration of time, followed by about a 2-week placebo to assess for any withdrawal. What they found were improvements in quality of sleep and quality of life maintained throughout the treatment period. There were frequent side effects, and those are important to note, which I'll note here with melatonin, including fatigue, somnolence, which is sleepiness, and mood swings. So those are side effects that are to be aware of melatonin. But there was no evidence of delay in BMI or pubertal development. So it was nice to have this very rigorously designed study showing this evidence, and even made me feel better as a clinician to be discussing some of these safety things with the individuals that I treat. I think another thing that's important to note, and I don't bring it up here, there was actually a recent JAMA network research letter looking or just alluding to the fact that not much is the use of melatonin has increased quite a bit in all individuals, it's not autistic individuals, across the last couple of decades, but not much is known about the safety profile or side effects. And that is true. I think there still is a lot of study. I think overall as clinicians, we feel pretty good about the safety profile, but there is still more we need to learn. But really what I'll go back to, and even that article addresses, is the fact that these melatonin supplements are over the counter. And oftentimes they can be mixed with other things, or it can be a mixture of a few different things, melatonin plus magnesium plus something else. So what I counsel clinicians and patients on is really to be looking for those that say just melatonin, and knowing again, it may not be fully regulated, but rather than something that's mixed with other things. So we have an idea that we, at least based off the label, are just giving melatonin and not melatonin mixed with other items. And as much as the concentration that we can be aware of, making sure we're aware if it's in liquid form, we know exactly what the concentration is, and we're dosing appropriately. So nice to see this initial study. Overall, generally the profile is thought to be safe. There are side effects, of course. And now what I will say is I have had patients, and it has been noted that there could be paradoxical reactions to melatonin. And if that is the case, then of course, I'm not going to keep pushing it. We're going to move on to something else. So let's move on to pharmacologic treatment that is, again, off-label. And I allude to a few different studies here, and we can kind of talk through what I'm also putting in here, which is some of the clinical treatments. I'll add in experiences of use of these two. So aside from melatonin, another medication that has been studied in autistic individuals is gabapentin. And in one particular study, or this study, they used a dose of about 5 to 15 milligrams per kilograms. It improved sleep in up to 78% of individuals. And it's known that this was only, though, about 23 children. There was an adverse event in one participant, which was agitation, and 5 described this sort of wired, or what we call, again, maybe even a paradoxical reaction, and increased difficulty in falling asleep. So knowing that it can have benefits, I do have colleagues that use it, but it also can have side effects. It's also important to know other side effects of gabapentin can be dizziness. There is drowsiness, one of the reasons that we use it. And so really with all of these medications, my goal at least is to start with a nighttime dose. Of course, that's what we're addressing, but sometimes gabapentin can be used for other neurologic conditions. And even if that's the case, I'm still always starting with a nighttime dose in an effort for the individual to be able to get used to that and not be affected so much by that somnolence during the day, which can affect, of course, school, work, and many other things. The other two classes of medications that I'm going to talk about are alpha agonists. So the first one is clonidine. And alpha agonists, are in the context that I'll see here, are used for sleep. They have been studied for many other things. One of the main sort of early things were blood pressure. So of a side effect we'll talk about. They've also been studied in autistic individuals for things like ADHD and impulsivity. But let me first focus on sleep and then talk a little bit more about clinically other reasons why. So clonidine, usually used at a lower dose, about 0.05 milligrams, that's half a tablet, to 0.1, which has shown to improve sleep latency and decrease number of nighttime awakenings. And so really here, when we talked about melatonin, we were talking about sleep onset. With these alpha agonists and really these other medications, we're talking about not only targeting sleep onset, but sleep duration, so sleep maintenance overnight. So if we've used melatonin and we're still having multiple nighttime awakenings and address behavioral areas, this is when we're thinking about these alpha agonists. And as you can see, the studies have shown these sort of things of decreased nighttime awakenings. Not so much, to a lesser degree, sort of improve things like hyperactivity and aggressiveness. And the reason I put that there is because this medication has, sometimes clinicians will use it to treat both irritability or hyperactivity and sleep difficulties. The other medication within alpha agonists is guanfacine. So again, generally starting with a lower dose, a half a tablet at night up to 1 milligram at night, but really half a tablet at evening to help sleep maintenance. And here where studies have shown also benefits of guanfacine to treat impulsivity and ADHD symptoms in autistic individuals. One large study done in children about 8 to 12 years of age, I believe, using guanfacine to particularly address ADHD symptoms. And so in general, when we're thinking about medication treatment for anything, the idea is really trying not to use polypharmacy or use many medications. And if we are having sleep difficulties as well as some impulsivity or attention, maybe trying to target that with just guanfacine can be beneficial. But also considering what I mentioned earlier in the talk, which is poor sleep can really augment or compound daytime attention as well. Trazodone is another medication which really has not been studied or well studied, particularly for autistic individuals. What I'll say is clinically or anecdotally, myself and other clinicians may often use this if an individual is refractory to other medications. But it's really important to know that there are side effects to the trazodone. We want to monitor things like what we call QT prolongation, so it can affect heart rhythms, and you have to have screening for those things. And similarly with side effects with clonidine and guanfacine, they can affect and lower blood pressure. So it's really important to be monitoring these things once an individual has started, to be getting blood pressure measurements at the primary care office or even within your own office, and making sure that these are okay. Another important thing to note is with these medications, and I'll particularly allude to the alpha agonists, because they can affect things like blood pressure. If a child has been on a higher dose or been on for some time, you cannot immediately take away this medication. It is generally recommended to taper it down so that you don't get a rebound high blood pressure with that. So these are some of the medications I mentioned earlier, but what I'll say is we talked about behavioral, we talked about this pharmacologic, we talked about cognitive behavioral therapy, and there have been, but really need to be more studies around cognitive behavioral therapy to address insomnia and address sleep difficulties. There was a study done recently by McRae et al. Using telehealth pilot studies, especially during COVID, to look at cognitive behavioral therapy, to look at insomnia. And they used measures, reports, as well as actigraphy and arousal measures. And what essentially they saw were positive results using this cognitive behavioral therapy during the trial. And what they allude to is that we do need larger studies and more randomized controlled trials utilizing these methods, because they can be really beneficial. And particularly when we think about a time during COVID, although hopefully with improvements, how these can be implemented from a telehealth perspective. So to summarize, I really want to emphasize that it's very important to always screen for sleep issues in general and in any setting. And predominantly because, not only because we want to be, they're prevalent, but they can really be pervasive to many different aspects of life, and can really compound other areas that if we were to help sleep or target sleep, we might see benefit in, and it might keep us from treating those things with other medications, or recognize that the individual is having those difficulties because of poor sleep. But I want to emphasize again that sleep is really variable for any child and any individual. So it's important that I go through practice parameters and medication recommendations here. But as a clinician, as a parent, as a person, I think it's really important to be very realistic with families and recognizing that it is a stepwise process, and we have to find out what works best for the family and for the individual. So even though we go through each of these things, which I'll kind of go through, the idea is never that it's a Band-Aid, that you have to rip off everything that's happening and implement all of these strategies, because it's not possible, right? And it can also lead to a lot of other difficulties that we might not have expected in general, how the family is trying to adapt with other therapies, with school, with other children. And so really what I try to say is a stepwise process. Let's target one or two things first and then move through other areas that we want to target. So again, starting with behavioral strategies and modifications, considering melatonin as short acting if sleep onset is a problem, considering melatonin long acting if night awakenings are a problem. Generally, I recommend using melatonin for at least 2 to 4 weeks consistently with a sleep diary. And then if there are other still issues, then considering other medications or strategies. And something that I also should add here, and I kind of noted on the previous slide, is also considering what other medications the individual is coming to you at prior to addressing sleep. And what I've sometimes found is, what I also noted is so many medications have maybe been added in an effort to address other areas of difficulty, that sometimes those medications can be contributing to sleep difficulties, like stimulants or like SSRIs. And so along with all of these things, what we really try to do, I recommend, is going through a complete sort of medication history and thinking about what's being used for what can maybe be changed so that we can target that before adding on something new to target sleep. So with that, I'd like to thank you for your time, and I would be very happy to answer any questions. I do want to make sure, because we are going to go in questions, and Maddie, you can let me know. I just want to make sure that we show these. So Maddie, I'll let you maybe, hop in, and then I'll answer questions so that we don't miss these slides, or let me know how you'd like to proceed.
Yeah, sure. Well, thank you again, Dr. Wilson. This was an amazing presentation. We'll go ahead and answer the questions, but here's our social media information, and then a link to join our webinar next month, which should be in the next slide, I believe.
Yeah, let me.
So in honor, sorry, this is an updated information, but in honor of Autism Acceptance Month, we have 2 presentations. The first hour, it will be Drs. Lindsay Shea and Christy Anderson from the Drexel Autism Institute, and they will be presenting on the National Autism Indicators Report from 2021. And then the second hour will be Dr. Jenny Maifan presenting on pubertal development in autistic youth. So, and let me go ahead and put that in the chat. We'll send out some more information later. All right. Yeah, so let's go ahead and do questions.
Would it be okay if I stop sharing for a moment so I can see the whole? Okay, sounds good.
Definitely.
So I'm not a black box here. So
no worries.
Right.
Yeah, so I think one of the first questions that came up was, can these effects happen to adults with autism as well?
Can these sleep difficulties, I think, is what? Yes, most definitely. And I actually think that's really important to know in general. I think sometimes, and even if I use some of this terminology, we say autistic children, or we think about young children, but the reality is it can happen across a lifespan. And what I'll say, and again, bringing some anecdotal clinician as a neurologist and somebody who often deals with this, it really should be screened for an adult. And that's where I often find that maybe polypharmacy or a lot of other medications have accumulated over time. And we need to get back and say, okay, what are these medications being used for? Are they impacting sleep? Or is poor sleep contributing to this? And if that's the case and we're addressing sleep, then we might see benefits in other areas. So very much can happen in adults, and very important to screen across a lifespan. Let's see, whatever. I think the next question, Maddie, is it okay if I kind of look through and see? Is that?
Of course, definitely.
Yeah. And so I see, what is the ideal? How long before bedtime does my kid need to stop screen time? Okay. So I will say ideally, what I try to say is an hour before bedtime, screen time stopped would be ideal if possible. I think for a few different reasons. I think one, that helps just address right before sleep, not having that light. And also sometimes as the bedtime routine starts, which can sometimes start up to 30 minutes before bedtime, maybe longer for some individuals, maybe shorter, depending on what's best for the family. It's nice for that not to be any part of the bedtime routine. I also say an hour because sometimes before we even know it's an hour, suddenly it's only 45 minutes before bedtime. And that gives us enough time to make sure that within that 30-minute window, that's not happening. Another question was, do you know anything about adding magnesium to help I think it's supposed to be prolonged sleep. And so what I'll say is that there is, and I won't speak to exact studies because I don't have them up here. I've looked at magnesium is thought to be calming, and there have been some studies used as a nutraceutical, I would say, to help with calming or to help with sleep, or just, decrease kind of hyperarousal, I should say, overall. And so I do have a lot of anecdotal families saying that magnesium can be beneficial. I think overall magnesium is generally a safe supplement used in certain amounts. So I don't want to say, go and use it or recommend any amount, but it's not particularly known to help sleep maintenance. Not really even sleep onset, but I can't actually note exact studies saying what that's shown or sample sizes, but overall calming effect, yes. I have a question about something about starting a Abilify for sleep issues. I don't see this on the list of medications. What are your thoughts on this medication? So, I think it's a good question. What I'll say is, in terms of thoughts for this medication, I'll offer more why I use this medication or if I use this medication. So Abilify is FDA approved, to treat irritability in autistic individuals. There have been good studies of both risperidone and Abilify, both in similar classes. Generally referred to as atypical antipsychotics, but really used for a broad range of things. Abilify can cause drowsiness, and sometimes it can help with sleep. I do not use it primarily for sleep. I use it if we are really trying to address irritability, maybe behavioral dysregulation. But what I mentioned earlier was sometimes if we are trying to address difficult areas in more than one area, both for the individual or for the family also, and sleep is also an issue, then maybe your clinician is trying to address both of those things. But it is not a medication used primarily to help sleep onset or sleep duration. That being said, I don't know the scenario situation. There's a possibility that maybe a lot of other medications have tried, and that's why the clinician and you guys are considering that medication. This was an excellent evidence-based presentation. Thank you so much on sleep. Oh, well, thank you. That was a nice comment. That can apply to any population. Thank you. I appreciate that. There's a question here about what the family should do. I think, so for families, really what I would recommend is, I do think it's helpful speaking to your clinician for some guidance, because I know oftentimes there is an attempt to try to navigate a lot of these resources that might be available, or when we Google can be both really helpful, but also overwhelming in the number of resources. I'd say, if not a clinician, my personal recommendation was actually be going to a couple of the links that I sent over, because I find them beneficial, and I think they help some of the initial behavioral strategies that can be used and that can be implemented. And so my thought would be probably to go to that first, but really, if as you are listening to this talk, if you're finding that a lot of these issues are resonating, then probably talking to your primary care provider, or if you have a sleep specialist or neurologist about these issues and ways in which to support these sleep difficulties that exist. Another question is on bedwetting for 7-year-olds who have previously been potty trained without issues. So what I'll say is, in the primary care setting, and I don't want to speak out of turn here because it's been quite some time since I've done my general pediatrics training, but I do come across this. Really, the first things that we want to rule out are there no other infections or other thing going on. So I don't know the degree of bedwetting. I'm not sure, how often it is or not, but if it is really new and not something that's kind of been occurring on and off, you may just want to check in with the primary care provider to make sure there's no infection or something else going on. But it can kind of be a range of things. It can also be in the realm of something happening, but probably a check-in with the primary care provider to make sure there's nothing else that needs to be ruled out. That's a really good question, Jasper. Is there a brand of melatonin that you recommend? And potencies can vary greatly across brands. That's very true. And that's actually one of the reasons why, or what was addressed in that recent JAMA paper that came out in February, which is they can change from brand to brand. And it's important to know about the potency that we're using. In all honesty, I don't have a brand that I recommend. And, because there are so many and there are several reasons why brands can sometimes change and distributions can change. But what I will say that are often go-tos and made in these different ones are Nature Made, for example, is one that offers different types that can be helpful. Trader Joe's used to also offer a gummy that I often found was just melatonin and was beneficial for a lot of families. But what I can to answer that question, Jasper, is really making sure in terms of potency that whatever brand that you're going to, the only listed ingredient is melatonin. It is not 10 or 2 or even 3 other things that are there, because that's generally the case across brands. And there's some that just make melatonin, and that's probably what I really feel most comfortable with. I'm just making sure on time too. Read about the value of sunlight and its benefits for sleep. Any studies have looked into this? There are studies. I don't know exactly the data on those studies, but what I can say is the whole sort of thought or idea behind sunlight is just regulating your circadian rhythm. So in the reality that, you don't want to keep your room dark all the time or be in dark settings, but in those who are having sleep difficulties, regular exposure to light during daytime hours, and at nighttime, a dark, cool, dark room is important to help that sort of circadian clock knowing that it's time to go to sleep. So lots of studies, yes, but really in terms of maintenance of circadian rhythm. I'm an autistic mother of an autistic child. Thank you so much for attending. Thank you for this webinar. Thank you, and allowing it to be accessible for multiple backgrounds. Thank you very much. I appreciate that. That was my goal here, to try to be a range. Shula, thank you so much. Any insight on how and when you would decide behavioral strategies aren't working well enough and move on to melatonin or medication? Yeah, really good question, Shula, and really kind of dependent per individual. And so what I'll say is that's really why I start talking about logs and diaries and addressing one thing at a time. And so, this is, and what I'll also say is really how much is it affecting the individuals and what other strategies that they've helped. What I'll say is I generally try behavioral modifications and strategies for about a month, because I think within that time, at least the first couple of ones can be addressed. We can start trying to move in that direction. And I'll give an example. I recently had a family that I saw, very lovely family, who has an autistic young girl and autistic son who both have sleep difficulties. And what they found, though, is leaving the TV on in the room. Both kids have to have that to be able to fall asleep and then sleep through the night, essentially. But if the TV turns off, then they may wake up. Now, let's look at one hand, right? As a clinician and even as a parent, the child is falling asleep and they're sleeping through the night. That's great. That's helpful for so many. But the hygiene probably isn't so great with the TV on there in the background. And there were a couple other issues I won't go into here. So the reality is my expectation is not for that family to turn off the TV on day one and say, sleep is bad, don't use sleep, and then create havoc. We used other strategies that are going to take some time to peel back to say, all right, we're going to allow 15 minutes into the night of TV, and then mommy or daddy or grandma or grandpa is going to switch TV to a recording, to an iPad, to a story, to a song. So there's some background noise. I want you to know that's what we're going to do. So when you wake up, you don't anticipate the TV being on. And we're going to try that for the first 2 weeks. Then we're going to move to reducing the TV a little bit more. By that point, if really those strategies haven't worked and they've been well implemented, then I'm going to start thinking about a medication addition. However, if some strategies, behavioral strategies, have worked and we haven't addressed all of them, and I don't think they're really contributing, but they can help sleep hygiene, then I'll do both simultaneously. And I'll just say, you've tried some strategies. This is really difficult. Let's start with melatonin. And I'll just add another comment in there is, although I went and the evidence really is that melatonin is helpful for sleep onset, this is again anecdotal. What I've found is when some of those behavioral strategies are addressed and melatonin is used for sleep onset, it can have this sort of regulatory effect. And I've seen some individuals who've had nighttime awakenings with just the addition of melatonin to help both of those things, just because we're working so well on regulating when falling asleep is happening. So to answer that, about a month, I'm trying those, and then I'm moving over to medications. I'm trying melatonin for 2 to 4 weeks before I'm trying something else.
Rujuta, there was someone who had their hand up
Oh, sorry.
during the whole person. No, it's okay. I'm just going to unmute their microphone.
Sounds great. Yes, yes, yes. Go ahead. I think I just put my hand up. I think, is it Dr. Irfan Sharif? If you had your hand up and would like to make a comment or ask a question.
Yes, yes. Yes, yes, yes.
I heard something, but perhaps maybe not. I'm not sure.
One last awful.
Maybe what I'll do, Dr. Sharif, is just answer a couple other questions. And then if you maybe still have a question or something, then you can put it in the chat or let us know again and we can unmute. Is that okay? Maddie, is that okay?
Yeah, I think that makes sense.
Is that okay? So go ahead, Dr. Sharif.
Hello. Hello, assalamu alaikum. I am Alfan.
Salam
And
alaikum.
my country of the Bangladesh. My organization name Autism Separation of the Bangladesh. My question the family. This is the family. This is the help is or not. The Bangladesh is a country. My question this answer.
Is it okay?
My organization Autism Separation of Bangladesh internationally I am international lions my father international lions 4-5 जन मेरी हिंदी भी आती है उर्दू भी आती है चाइनीज भी आती है इंग्लिश में नहीं आती क्या कहूँगा ना
Dr. Sharif, I think I appreciate it. Maybe you want to put in the chat. Thank you for trying, but I think we might move on to another question.
Thanks.
No, totally. Yeah. Thank you so much though. And thank you for attending. But please feel free to put any of that in the chat as well. Okay. So, let's see a couple others. For a child with a history of epilepsy. So what I'll say is, I think history of epilepsy versus epilepsy, right? So one thing with epilepsy is we really just want to make sure we're treating the epilepsy because seizures can disrupt sleep. And we want to be mindful of making sure that seizures are well treated because they can obviously impact many other developmental areas. But regardless, if seizures and epilepsy are well controlled, then we are still going to use some of these pharmacologic agents for sleep as well. With a history of epilepsy, but no longer having epilepsy, if there are sleep difficulties, what I want to screen first for is, are we concerned again for any seizures? And through clinical criteria, if we're not, or through an EEG, if we're not, then we're still going to use the same medications to target these sleep, knowing that maybe, other third, fourth line medications, if they have a lower threshold for seizures, we're going to be aware of that. I hope that answers the question as well. I have not heard of tri-layer sleep that has melatonin in as well, but I'll kind of go back to really my recommendation starting out is just a formulation with melatonin. So a starlight projector, what I'll say is I think night lights in general really are individual dependent. And what I'll say is particularly during toddlers, sometimes night or later childhood night lights can actually be beneficial and help with other parasomnias that we call, or just the scaries of sleep. And so I think it's individual dependent. I think if without a nightlight, if the dark room can be comforting, we'll try that first, but just a nightlight is okay as long as it's not really filling up the room. I know we have 1 minute. Should I try? Let's see.
Yeah, we have 2 in the Q&A
okay, let me
panel.
I'm trying to look at all of the different areas. All right, let's see. There were a lot of points about the impact poor sleep can have but I know are there challenges for sleep? Yeah, Jeff, great question. And I think, kind of what I was going through there is that particularly for that are unique to autistic individuals, were some of the things that I went through. And when we think about other common co-occurring conditions that we often associate with autistic individuals. We think about poor sleep compounding some of those, like attention, anxiety, and we want to be mindful of the fact that if this is truly the case, then we're approaching this in a holistic view, be how sleep can impact those particular things that are more common in autistic individuals. Evidence that too much melatonin can cause more problems with insomnia. So what I'll say is that's sort of the concern, being that we don't really know in terms of level or amount of melatonin, but a side effect can be paradoxical as well. So I'm trying to be mindful because I know we've also hit the hour, so I don't want to. I want to answer these, but get to it otherwise. So, so the question of that being the fact that I think we still need more data on melatonin, but in some it can have a paradoxical reaction. So we want to be mindful of that. That melatonin causing insomnia instead of promoting sleep. I think I've targeted all of them, have I? Or are we?
Yeah, I think there was one question at the end of a comment, and it was, how does having TV on affect hygiene while asleep?
I think, we were talking about this a little bit. So what I'll just say is really, those studies behind screens and screen time and that light from screen that can really disrupt sleep. So ideally, no screen time at least an hour before bedtime, and really not having the TV on overnight as well is my recommendation. So thank you everyone very much for attending. Thank you so much for the great questions. I also really appreciate the questions that came both from personal, from families and caregivers, as well as practitioners. I think these are really relevant, important questions. And thank you for your time in joining me today. And I look forward with engaging more in future webinars. Thank you so much. And thank you again to the ARP and to HRSA.
Thanks, Rujuta. And then let me put the survey, the post-webinar survey link in the chat really quickly as well. All right. Thank you again, everyone. Have a good rest of your day and see you next month.
Thank you.
Thanks again, Rujuta.